Hey guys, Mike here from the Ultrasound Podcast. You know, we tend to lean toward the new and exciting, cutting-edge material on the podcast because, well, we find it new and exciting. But sometimes you got to recognize the basics and teach a little good old-fashioned ultrasound. This next podcast is a live recording from CastleFest 2018. Jacob got handed the baton of teaching the one lecture I consider cutting every single year, the FAST exam. You know why I think about cutting it? Because I mistakenly assume everyone knows how to do it. Then, every year, I realize 50% of us are doing it wrong, or we don't really know it as well as we think we do. I learned something from Jacob's talk this year, and looking back on it, I learned something from talks like these every year, no matter how well I think I know them. So let's take it back to the old school today, with some good old-fashioned learning you can use in everyday practice. Take it away, Jacob.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Hello, everybody. Like I mentioned earlier, my name is Jacob. I work here in Kentucky as of July, and so far so good. Although last year I couldn't breathe or talk because of allergies. And it turns out that I am the most allergic. I'm allergic to nature in general, but I'm most allergic to Kentucky bluegrass. So we'll see how well that goes on this year. Does anybody remember that I couldn't talk last year? It was rough. So today, what we're going to talk about now is trauma ultrasound. And usually when we talk about trauma ultrasound, what we're talking about is essentially this, the eFAST, or the Extended Focus Assessment of Sonography in Trauma. Whenever I'm talking about ultrasound, potentially adding something new, I always ask myself why. Why would I add something else? And the reason why is because the vital signs in the physical exam, sometimes they don't do as well as we think it's going to do. The specificity is pretty high. I mean, if you have a trauma patient, they have a bruised abdomen, they're hypotensive, they're tachycardic, they're screaming, they're not intubated, you can actually get an examination. The physical exam is useful, right? But a lot of our patients are not going to be that way. They don't read textbooks. The human body is going to do whatever it is that it feels like doing, and we need something else. How many of our patients are on medications that artificially lower their heart rate? At least here in Kentucky, it is a lot, right? So this patient might actually would love to generate tachycardia, but can't because of the calcium channel blocker or the beta blocker they're on. Additionally, I don't know if you guys have heard of this, but there's this thing where you get relative bradycardia with hemoperitoneum. It's something that's been actually well described. You see it in trauma patients, you see it in ruptured ectopic pregnancies, and the theory is that the blood actually irritates the vagus nerve. It can actually cause a relative bradycardia when the patient would love to actually have tachycardia. And there's a whole blood pressure issue. You know, I've heard people say, well, the blood pressure is 110. They're probably not. They're not at a stage of blood loss where it matters. Maybe for probably most of us, but what if our patient's average blood pressure is 190? What if that's their baseline blood pressure, which I see a lot? A baseline blood pressure of 190 all the way down to 110 to that patient is hypotensive. Additionally, a lot of our patients, if we're concerned about trauma, they're going to be in pain. Pain artificially increases that blood pressure. Vital signs are not as useful. You got to get them in all your patients, but they can definitely lead you astray. Physical exam as well can lead us astray. And how many of our patients have abdominal pain, right? A lot of them. So we need something else. We need that ultrasound. So I'm here talking about physical exam, talking about vital signs. What about ultrasound? How accurate is it? Can we use this? The answer is yes, under certain circumstances. So there's two ways we can answer this accuracy question. Positive or negative, yes or no, or how much fluid needs to accumulate before it will be positive. I kind of think that the more important question is the second one, the minimum fluid detectable. If you look at overall patients with severe intra-abdominal injury, specificity is pretty good. It doesn't matter what study that you see. If you see in a trauma patient fluid in that belly, the chance of them having a significant intra-abdominal injury is pretty high. Sensitivity is all over the place. When you look at these studies, there are some studies that had really good technique. They had really high-resolution machines, and some of them not so much training, not so much good machines. So understand that a negative FAST does not mean that your patient does not have an injury. What I like to focus on is this minimum fluid detectable, and that's important. Once you get past about a Coke can, you're pretty specific. The specificity of those studies that only looked at fluid that was more than about 300 to 400 cc's of fluid, 300 cc's is about a Coke can, then those are the ones that all show that high specificity up here. So know that if you see fluid in the belly in a trauma patient, the likelihood of them having blood in their belly is very high, and they have at least a Coke can. Although there's some studies that, especially in the pelvis, it can detect as little as 100 cc's of fluid, which is pretty good, I think. All right, so let's talk about, that was the belly part of the FAST exam. We're going to do the eFAST. We're going to go a step more, which is the extended FAST. Let's talk about pneumothorax. Let's talk about how we do by listening at that patient, trying to figure out if we have equal breath sounds or not. Sensitivity, it's not very good. Sensitivity of auscultation, it ranges between about 50 to about 62% in the literature. It's about coin flip territory, right? Specificity is good. If you're like, this is definitely absence of breath sounds on this side, I think you can use it, but you can't rule it out with auscultation. Chest x-ray, the thing that we always use in trauma patients, right? You have that supine patient, you're trying to get that x-ray. That supine trauma patient x-ray has a not so good sensitivity. It's a huge range here. It ranges from 25 to 75% sensitive. How do you guys think ultrasound does? Significantly better. This is sensitivities, by the way. So the sensitivities range from 86 to 98%. There was 4, I think there's actually a 5th one that's come out recently, meta-analysis, that I've looked at these trauma patients and found that the worst that ultrasound does is better than the best that x-ray can do. So we really should be using ultrasound to evaluate our trauma patients. The last part of it is tamponade. You guys heard of Beck's triad, right? We all learn this, and we all learn that that's what our tamponade patients will have. This is how often they're present in patients with tamponade. JVD, about half, and that's the best one that we have. These things aren't as useful as we might think. We're actually really good at detecting effusions on ultrasound. This was a study that was in a pretty big N, 515 patients, specificity of 98% and a sensitivity of 96%. That is really accurate, and this is us doing it at the bedside. This is not cardiologists. Now, there are a couple things you can do to increase your sensitivity. You want to be the most sensitive you can. The easiest one is to make sure that your technique is good. Learn how to do a good FAST exam. Learn where fluid will accumulate, how you can position the patient, how to repeat your scan. It's another thing, repeat your scan. You're not only allowed to do one FAST per patient. If you do a FAST on a patient, it's negative, you still don't know what's going on, and it's been about 10 minutes, re-scan them. In that time, if the patient has a significant intra-abdominal injury, that might be enough time for that fluid in the belly to get to that threshold where you can actually pick it up on your ultrasound. And then with positioning, you can position and put them in Trendelenburg. You'll be a little more sensitive in the right upper quadrant because fluid will accumulate in the right upper quadrant. If you put them in reverse Trendelenburg, you might be a little more sensitive in the belly. All right, let's talk about how to actually scan. Let's start with the abdomen. Kind of alluded to it. There are 3 different places they need to look in the belly: the right upper quadrant, the pelvis, and the left upper quadrant. And I put this in this order on purpose. That is the order in which you should be doing this FAST examination, because the FAST exam is a binary question. Is there fluid in this belly or is there not fluid in this belly? If you have a positive FAST in the right upper quadrant, you're done. You have found fluid. Now you have to go to the OR or straight to the CT scanner, right? If you don't find it in the right upper quadrant, go to the pelvis. It's the next most likely place for fluid to accumulate. It's a little bit counterintuitive because, like, in a trauma patient, especially a blunt abdominal trauma patient, what is the thing that gets broken first, that leaks? It's the spleen, right? Even though the spleen is the most common thing to cause hemoperitoneum, it's still more likely to be present on the right upper quadrant. A lot of factors. It might have to do with the fact that blood likes to travel where it's easiest for it to travel, and it's actually easier to get a window in the right upper quadrant versus the left upper quadrant. It's a little difficult to get a window up there. So start right upper quadrant, then pelvis, and left upper quadrant. The ultrasound is a 2D imaging modality. So you're using a 2D imaging modality to evaluate a 3D structure. So in order to do good at this examination, you do have to do a systematic approach. The most important part of the right upper quadrant is up here, this top one, Morson's pouch. I should put a little asterisk on that Morson's pouch, because the traditional Morson's pouch is going to be just between the kidney and the liver, right? But you have to extend that little area all the way inferiorly to make sure that you get the inferior pole of the kidney and the caudal tip of the liver, the lower lip of the liver. There's a little triangular space right there. That actual triangular space is where fluid accumulates first. So you have to get that part first. So it's the extended Morson's pouch. You have to look there. Look subdiaphragmatic, that's above the liver. It can definitely accumulate there. The pericolic gutter is just basically bringing it down a wrist space or two on the side, just to see if there's any fluid in that pericolic gutter. And then while you're in the right upper quadrant, go ahead and look and see if they have a pleural effusion. In a trauma patient, you'd be concerned about a hemothorax there. In the pelvis, it's not, that's probably the least complicated place. You just got to look suprapubic in the pelvis and fan through that area. The left upper quadrant, it's a little bit different. The left upper quadrant is not a mirror image of the right upper quadrant. The most important place to look in the left upper quadrant is actually supradiaphragmatic. You have to look above the spleen and below the pleura. That's where fluid likes to accumulate first there. But it's a 3D organ, and like I mentioned in previous slides, patients' bodies want to do whatever they want. So make sure you scan through that whole thing and evaluate the entire area around that spleen. My favorite probe to use for the entire eFAST is going to be the curvilinear transducer. This one has a good mix of frequency. It's got a good resolution, also gives you a good depth. Sometimes people mention that this is an issue because ribs get in the way. It's an easy way around that. You just turn your transducer a little bit in line with the ribs, then you have this giant field of view without any ribs in the way. This is my favorite. If you have time, you can actually do these other ones. The phase array transducer, the one over here, the cardiac transducer, this one would probably be a little easier to get a good subxiphoid view. It's kind of difficult sometimes to stick the curvilinear in the subxiphoid area. And then, although you can easily see a pneumothorax with a curvilinear transducer, your linear transducer here, this one's going to be the most sensitive. So you have time, you have the probes, you can switch, but you can definitely do the entire thing just with the curvilinear. So like I said, start in the right upper quadrant. You want to place it around the mid-axillary line, around, I don't know what rib space is, but I call it the inner nip line. So basically like draw a line across the nipples all the way down. I stick my probe right there. Landmarks really aren't that important because everybody's anatomy is going to be a little bit different. If they have a lot of abdominal obesity, it's going to be a little higher. If they have really bad emphysema, their ribs are going to push everything down, or their diaphragm is going to push everything down, and then your area of evaluation is going to be a little bit lower. And you're looking for this image right here. Now this right here, this is Morrison's pouch right here between the kidney and the liver. But this is that spot I was talking about. This triangular area right here is the area where fluid will accumulate first. That is the most sensitive area in the right upper quadrant. You have to make sure that you get a view of the caudal tip of the liver and the inferior pole of the kidney to get an adequate right upper quadrant view. Remember, 3D structure, fan through that whole thing. So see, I'm not just doing one slice, taking the still and being done. I'm actually fanning through the whole liver to make sure that in my mind, using this 2D modality, I'm able to generate a 3D image to adequately evaluate. I can't emphasize enough, this is where fluid accumulates, right here. This is Morrison's pouch, and you have to extend Morrison's pouch out to this area right here and evaluate fluid. Here's a positive fast. Fluid is dark on ultrasound. It's hypoechoic. You have the liver here, you have the kidney down here, and you have right here this free fluid. This is a positive fast. I know everybody's got a favorite right upper quadrant ultrasound that they've saved. This is my favorite. What do you guys think about this? Is it a positive fast or a negative fast in the right upper quadrant?
This is your favorite?
It is. I'll show you why. This is my favorite. I know he's incredulous, but I'll show you why. So if we just did the Morrison's pouch view, like we're like, oh, it's just Morrison's pouch here, it's a negative fast if we just look there. But I'm going to move down a rib space right here and show you why it's so important to get that area down there. You see how much blood is in this person's belly? This is why it's so, that's a pericolic gutter, by the way, as you see all these little things right here. So there's so much blood down here that if I only looked at Morrison's pouch and didn't remember that I had to look inferior to the liver to get an adequate view, I may have missed this. While you're here, go ahead and just look for a pleural effusion. You have to go a little bit above the liver for this, and when I get down to the chest, I'll tell you how to find a pleural effusion. But you should go ahead and just do this for both your right upper quadrant and your left upper quadrant because you're already there. Why not just do it there? All right, let's move on to the pelvis. My favorite view here is to make sure that you look with a probe in a sagittal orientation with the probe marker up. Usually when you're starting out, if you have any issues with this, it's because you're too high. You have to go low. You have to go uncomfortably low with that transducer. You have to place it right above the pubic symphysis, which is like a couple of centimeters above the genitalia. So it's kind of uncomfortably low. If you're having issues, actually with my non-dominant hand that's not holding the transducer, if I'm having trouble, I'll try and find the pubic symphysis and then just stick my probe basically right on top of the pubic symphysis. You got to go lower. There are two ways to evaluate this. There's a transverse and a sagittal orientation. So transverse this way, sagittal up. You can do both. There's no harm in doing both, but I've never gotten information from the transverse view that gave me information that the sagittal view hasn't gotten me, and the transverse view for me can be confusing. It's a transverse view. What do you guys think? Is it positive fast or negative fast? The bladder's here. Remember, fluid is hypoechoic. Do you guys see these two little things down here? Right there? And right there? This is what a positive fast looks like. Fluid accumulates just like this. The problem is that those two fluid-filled structures down there, those are physiologic structures. And what happened was my probe was angled, and this is a transverse cut here. My probe was angled a little too inferiorly. I actually was not in the peritoneum. I was below the peritoneum. What I was looking at there were seminal vesicles. What you need to do is you have to make sure that you're actually looking into the peritoneum. And in a transverse cut, sometimes it's difficult to know where that person's peritoneum starts and where it ends. So what I do is I always look in a sagittal orientation, because in a sagittal orientation, you can tell where the peritoneum starts and where the not peritoneum is, so prostate and seminal vesicles. So this is what we were looking at earlier. This is bladder. This is peritoneum. A patient's head's over here, feet over here, anterior abdominal wall here and back, so they're laying on their back. This right here, this is a prostate, and this is fluid in the seminal vesicle. This is a physiologic structure. This is not a positive fast. And this is both male with seminal vesicle, and that is what free fluid looks like. So this is peritoneal. This is not perineal down here. Anatomy is a little bit different in females. If they have an aneverted uterus, the fluid usually is going to accumulate back here behind the pelvis. And if they happen to have a retroflexed uterus, it often will be in between the uterus and the bladder. And here's a positive fast. We got our bladder here, uterus here, and this is a sagittal cut. And then right there is a positive fast. Little caveat with positive fast in females, especially in younger females, you can often see a little bit of free fluid in that pelvis, and it be physiologic. So this is the one case. If I found this fast in a hypotensive patient, maybe an 18-year-old female, I would be concerned, but I don't know if this is what's causing that patient's hypotension, because females can have a small amount of physiologic free fluid in their pelvis. If I see a right upper quadrant positive fast, though, that's definitely like a traumatic issue, especially with abdominal pain. But be careful in the pelvis in females. Left upper quadrant, this is probably the hardest one, but like I mentioned, this is the least likely for you to pick it up, or the least likely for it to be positive. Right upper quadrant's more important. The left upper quadrant, it's not a mirror image of the right upper quadrant. You're evaluating a different area and in a slightly different place. So with the right upper quadrant, we're looking here, right? Like the mid-axillary line, right at the inner nip line. With the spleen, you want to go to the bed and to the head. It's a smaller structure than the liver, so you got to go a little more posterior and a little more set flat. So you want to go basically right up here. And you'll get this image here. I'm going to flip it so it looks like the ultrasound. And this is the ultrasound image right here. We have spleen up here, got kidney up here. And remember, with this, not a mirror image. We're not looking at the exact same thing. What we need to look for is we need to look at the area that's suprasplenic. We have to look at this area right up here between this white line, which is the diaphragm, and the spleen. This is where fluid likes to accumulate most commonly in the left upper quadrant. Remember, blood's going to accumulate wherever it wants. So you still have to fan through the whole thing. Still do the Morrison's pouch equivalent on the left side. But you do not have an adequate view until you've done suprasplenic. So this one's my favorite left upper quadrant fast. What do you guys think? Positive or negative? Now, I mean, if this was the right upper quadrant, like I might say, I don't know, I don't think that's fluid. I think that's a little bit of mesentery. I don't see any fluid there. I see a good inferior pull of the kidney there. A caudal tip of that will say liver. I see most of it. I don't know. It kind of looks negative to me. Maybe a little spine sign over here, so there might be something going on in the chest. I moved up a rib space on this patient that maybe had a negative fast, and you see this. That's why it's so important to understand positioning. Spleen, blood, diaphragm. This is where fluid likes to accumulate on the left side, so make sure that you look in that area. Now on the same patient, you can see that there's a little bit of blood in the paracolic gutter. So I usually will go a rib space down or two, down the paracolic gutter, just to make sure that I have the maximal sensitivity. Additionally, I mentioned that patients can have blood wherever they want. You can see like maybe a strip of blood, maybe a strip of black up here. Kind of hard to see. Very easy to see this rim of fluid right here between the kidney and the spleen. So even though it most likely is going to accumulate above the spleen, doesn't mean that that's necessarily always going to be the case. And here's a small amount of free fluid that we picked up down inferiorly. See that little bit of free fluid down there? And that's why it's so important to make sure that you spend a little extra time, the extra 5 seconds to do a slow sweep. All right, let's move on to the chest. There are two things that we want to evaluate in the chest. We want to look at the heart for tamponade specifically, and then we also want to look at the lungs, and that is looking for a pleural effusion or a pneumothorax. Let's start with the heart first, which I think out of the two is probably the most important. So the first question, there are two questions you're going to ask yourself in sequential order. Is there an effusion around the heart, or is there not an effusion around the heart? That's the first question. And then after that, is there an effusion or is it tamponade? Because that's drastically going to change your management, right? If it's just an effusion or if it's tamponade. So with this, the best way to get this view is going to be a subxiphoid view. Make sure that you get an overhand grip and kind of make sure that you're holding the head of the probe, because you really have to nuzzle that thing right underneath the ribs. The heart is sitting all the way up there, and you have to get the beam underneath the rib cage to actually be able to see the heart. So you have to kind of sometimes push a little bit hard. If you can't get this view, you can definitely try other views. You can try an apical four-chamber view. You can try a peritoneal long axis view. You can try whatever view you want, but this one typically is the easiest one to get. This is liver here. This is the right side of the heart here, right ventricle, right atrium, left ventricle, left atrium, and fluid is going to be hypoechoic. We're looking for a black band of fluid around that heart. What do you guys think about this heart? Got a good sized effusion, right? You guys see that rim of black all the way around that right there? It goes all the way even around there. Call this like a moderate sized effusion. Is it tamponade? I don't know. This wall seems to be kind of collapsing kind of well. It's a good sized effusion too. I know I've heard some people mention, you got like a trampoline sign, see if someone's jumping on it. It took me like a day. We're just going to watch this for a little bit because of how long it took me. Thank you. Yeah. All right, so one of these is tamponade and one of these is not tamponade. The way that you know the difference is you got to look for diastolic collapse of the right ventricle. There are other findings, but that's usually the one that we do, diastolic collapse of the right ventricle. Diastolic collapse is going to happen when these valves are open. So you're looking for chamber collapse with the valves open. So let's slow this one down. Look at when those valves are open and look when it collapses. So it collapses when the valves are closed. See? Valves closed, collapses. Valves open, it pops up. Valves open, it pops up. Valves closed, it collapses. So this is systolic collapse. When the valves are open, your ventricles are trying to fill, that's diastole. If you're trying to fill a structure and that structure is collapsing, that's when you get shock. That's when you get that obstructive shock. That is tamponade. This patient has systolic collapse with an effusion. They definitely have an effusion. Effusions are abnormal, but this patient does not have tamponade. Let's take this one right here. It's a little quick, so I'm going to slow it down. What do you guys think here? Look at when that valve's opening. This is the mitral valve here, to where the right ventricle, is collapsing, the right ventricular outflow tract. Notice that valve pops open, chamber collapses. Do you guys see that? This is tamponade. This is diastolic collapse of that right ventricle. This is bad. I know what you're thinking. I don't know. Some of the patients are tachycardic. I don't know. Is it diastolic? Is it not diastolic? There is a tiebreaker for you to help figure it out, and it's this guy right here. This is the IVC. The IVC is something that I use. I think it's helpful as long as you know what it's a surrogate marker of. The IVC is a surrogate marker of the CVP. If you have a patient that you're concerned that they have obstructive shock, they're going to have an elevated CVP. If you have a thick, dilated IVC that is not moving at all, notice this is not changing in diameter. As this diaphragm moves down, this IVC is not changing in diameter. This patient has a high IVC. If you have a patient with a big effusion, you're concerned you see this, it's a good chance that the patient actually has tamponade, has obstructive shock. If you have a heart that has tamponade physiology, you're concerned about it, but you see this IVC over here, it's unlikely to actually be tamponade. I don't know of a situation. I'm sure there's one, and if you know of one, let me know. I'm not sure of any situations in when you'll have obstructive shock due to tamponade and have a low CVP. The physiology doesn't quite make sense to me, although if somebody knows, please let me know. The only caveat to this is that if you have a patient, I had a patient in residency that had clot in his pericardium because he got shot, and his IVC was collapsed. I don't care that his IVC was collapsed. He had clot in his peritoneum, right? Make sure that you remember that your job is to be a physician. The ultrasound is a data point to help you. Just because the IVC is collapsed on that patient that had a gunshot wound into his pericardium did not mean that the patient did not need to immediately go to the OR. So just keep that in mind. All right, let's move on to my favorite thing of all time, the lungs. We're going to talk briefly about a pleural effusion because we have another lecture where we're going to talk about a little more. Now, there are two signs to look for a pleural effusion or a hemothorax. It's a mirror sign and a spine sign. Let's first talk about the mirror sign. Now, the mirror sign, if you look beneath, so this is a spleen here. This is spleen, kidney. These are spine down here. This right there, that white thing, that's the diaphragm. This is the patient's head. This is the feet over here, anterior abdominal wall, and back. If you look below the diaphragm and above the diaphragm, if the echo texture looks identical, like almost like a mirror, that's a mirror sign. What that means is you have something that is fluid-filled, like the spleen or the liver, and something that's air-filled, like the lung, right next to each other. The interface between fluid and air creates a highly reflective surface for sound. All the sound bounces off of that. If you see a mirror of what's below the diaphragm, above the diaphragm, that is a positive mirror sign, meaning there's air in the thorax, meaning no pleural effusion. That's not my favorite sign, though. My favorite sign is this one. It's the spine sign. You guys see these little arches right there? These are the lumbar and low thoracic vertebral bodies. Look what happens as the diaphragm shoots off. Do you see any more spines? I see no more spines. I see none of. See, there's like a white line here with these little like black little dips here. Disappears right there. Patient obviously has a spine in the thorax, right? What's happening here is that since there's air in the chest, the air is actually blocking the sound waves from getting to the thoracic vertebral bodies. If the sound cannot make it to the vertebral bodies, the ultrasound machine does not know they exist. So we lose the spine. If you see the spine not extend past the diaphragm, the patient does not have anything transmitting sound to the thorax, to the thoracic vertebral bodies. There is no effusion. Look at this guy here. I actually like seeing this, and you can practice this on the models today. So look at that spine right there, and watch what happens as the patient takes a breath. So basically brings the air further down by breathing, bring the diaphragm down. This guy disappears because that air is now blocking and getting in the way. And we have a really good mirror sign as well. So down here and up here, very similar architecture. This is not those things. This is the opposite of both of those things. So we look beneath. This is the liver here. This is the diaphragm, this white line. So there is a different echo texture above the diaphragm as there is below the diaphragm. This is a hypoechoic pleural effusion. You see the spine here. You see how now we can see it extending up past this thing, which is the diaphragm. We can see this part of the spine because this fluid is transmitting sound to the thoracic vertebral bodies. That is a pleural effusion, the setting of a trauma. It is a hemothorax. All right, let's talk about pneumothorax. Probe placement is important. If you have a hypotensive patient, you have a shock patient, truly it actually doesn't matter where you put that transducer. If someone has tension pneumothorax, they're going to have the absence of lung sliding, which is how you figure out pneumothorax. It doesn't matter where you look, they're going to have it. So I just put it in one spot, whichever is the easiest place to put. If you have a patient that's got a little bit, he's maybe soft vital signs, complaining of chest pain, but stable, you want to be as sensitive as possible. When a patient's laying down on their back supine, the second and third intercostal space, where it's where a lot of places say you should look for a pneumothorax, that is not the most anterior part of the chest wall. Remember, air is going to go closest to the ceiling, right? So instead of placing it in the second and third rib space and starting there, what I do is actually start more at the apex of a chest. So it's actually a little bit closer to rib spaces 5, 6, and 7. I'll usually start there because that is going to be your most sensitive place for a pneumothorax. And then I'll go ahead and look at the entire chest. And this is the anatomy that you'll see. So you get your rib shadows, you got some skin muscle up here. This white line here, this is called the VPPI, or the visceral parietal pleural interface. We just usually call that just pleura. This is what we're looking for. And we're not really looking for movement, we're looking for sliding. We want to see if this white line is sliding back and forth. Which of these is sliding back and forth, left or right? This one right here. This one, we have good lung sliding. Some people call it like ants marching on a tree or a log or something, and like gliding. Just is that moving laterally, basically. And this white line is still here, and I see a little bit of movement because this intercostal muscle is pinching because the patient's in respiratory distress. There's no lung sliding here. In a trauma patient, this is enough, especially if they have chest trauma on that side, this is usually enough to diagnose that patient with a pneumothorax. Now, this is very sensitive for a pneumothorax. So if you see this area right here, you have essentially ruled out a pneumothorax in that area. But this doesn't necessarily rule in a pneumothorax. It often does, but it doesn't necessarily rule one in. How many of you guys have ever heard a really bad asthmatic? Like you have to intubate them really bad asthmatic? Most of us, right? Maybe all of us. What do they sound like when you put your stethoscope on?
No air.
No air at all. There's no air movement whatsoever. You will also not see lung sliding because no air. You have to be moving the lung to actually be able to generate lung sliding. Patients with adhesions, patients with pneumonectomies, patients with big blebs, they all will have the absence of lung sliding as well. So you need something that is specific. You need this guy right here. This is the lung point. The lung point is very specific for pneumothorax. I wouldn't go as far as to say it's 100% specific, but it is very highly specific. You guys notice I'm using the curvilinear transducer for this? I like the curvilinear transducer because you don't have to switch probes in the trauma patient. You can see, I'm easily seeing lung sliding here and the absence of lung sliding over here. Or sorry, absence of lung sliding here and then lung sliding over here. This is where the pneumothorax starts. And you can actually quantify where this is. So if you have a patient and you see the lung point here, they're laying down supine, it's not a big pneumothorax, it's a very small one. Versus if you see it all the way down here in the side, it means that all of this part of the lung is air, free air basically outside of the lung. It's probably a big pneumothorax. And we'll talk about this a little more in the basic lung talk. So that was the eFAST. That's how we think about trauma in our ultrasound in our trauma patients. But there is so much more that you can do. It's not just about the eFAST. You can actually look for fractures. You can look for pulmonary contusions. That's one of the things that I do often is if I have a little bit of extra time, I'll look for a pneumothorax and I'll start scanning the lungs to see if I see any big pulmonary contusions. Lines. You get your hypotensive trauma patient, it may be difficult to stick in that central line in that patient they need it, or an art line. With the ultrasound, much easier. There's a lot of stuff you can do in the eye. You can look for eye trauma. Be careful. You don't want to put too much pressure if you suspect a ruptured globe. That's an obvious thing. But if you have a patient where their eye is super swollen and you can't see if they have a consensual light reflex, you can actually look at the pupil with your ultrasound machine in the affected eye, so the swollen eye, and then shine a light in the other eye to see if you have a consensual pupillary eye reflex. Look for retinal detachments as well, traumatic retinal detachments. Then you can look for ICP. Does the altered patient, do they appear to have an increased ICP? You can look at the optic nerve sheath diameter and see if it's enlarged or not. And a big thing that I've been trying to do more and more lately is actually doing nerve blocks on my patients that come in with extremity injuries. These nerve blocks can be amazing. I've had patients that have chopped off all their fingers. We have a lot of saw injuries here in Kentucky, I guess. A lot of gunshot wound injuries to the hand. Oh, by the way, do you guys know what's like the most common gunshot wound injury? It's self-inflicted. Like when you have a gun, you're more likely to shoot yourself. And it's usually when they're cleaning their guns. So it's in the hands, usually, when I've seen them. So you can do nerve blocks and be able to clean their wounds, fix them without any issues. My favorite block for this, by the way, is the superficial cervical plexus block that you do, not superficial, the supraclavicular brachial plexus block up here. Blocks of brachial plexus from here all the way down to the fingertips. It's an amazing block. Been trying to do these more and more for the nursing home patient, maybe doesn't walk all that well, has a little bit of dementia, comes in with a proximal femur fracture. Very easy block to do is a fascia iliaca block and makes it so that their likelihood of having pain control is lower, or the pain control is better, so their likelihood of poor outcomes actually down the road is actually going to be better because they're less likely to get delirium. These blocks are very powerful to do in your trauma patients. And that's the end of my talk. If you guys have any questions, you can call or email Matt. Or you can contact me. This is my website. I started residency where I have a lot of tutorials. If some of this is a little too much for you, I have like 40 or so videos on there that are, I say 5 minutes, don't know, but the 5, it's like the mean. It's usually, it ranges from like 3 to 8 minutes. Sometimes I get carried away. There's my Twitter, and then there's my email. Any questions? No? Great. Thank you.
Bro, are you stoked about Fiji or what?
You know it. I love me some apples.
No, man. Developing EM. It's in Fiji, and we're teaching ultrasound.
Dude, I got 4 kids now. I don't have time for a waste. Did you say Fiji, like South Pacific Fiji?
Yeah, man. Lee and Mark are back at it, and after a year off, are hosting Developing EM 2018 in Fiji, December 3rd through 6th. I signed us up for a pre-conference ultrasound workshop on December 1st and 2nd.
Sweet. I'm not really...
Don't worry about it, man. I'll handle the teaching along with a docket of international world-class educators. You can just come, look pretty, maybe learn some of that ultrasound you forgot.
I'm sold. How could I say no after those amazing experiences in St. Lucia, Brazil, Cuba, and Sri Lanka? Totally some of the most memorable experiences of my life.
And Developing EM isn't just parties and medical tourism.
Nope, they've got amazing world-class educators from the Alfred in Melbourne and Stony Brook in New York. And of course, they support emergency medicine development in the developing world. Why choose between doing something amazingly fun and doing something good for the world? Come to Developing EM with us and do both at the same time.